presented to chief complaint of pain, right side in central upper abdomen for last 7 months, vomiting off and on for last 7 months, and decreased loss of weight for last 7 months. Patient was presented of like 7 months back. Then he noticed pain in the right side abdomen, in the mid and upper abdomen, leading to the central abdomen also. Pain was of lot of specific intensity, and it's mild to moderate intensity, lot of specific character, and after having this food, 1 hour after having food, and he felt nausea. After vomiting, pain decreased but not completely disappeared. He has to go to doctor and had some injections to reduce the pain. The pain again appeared after 7 8 to 10 days, and then again the same episode. He again has vomiting, some decrease in pain but not completely.
See how much time has been wasted. It's a patient who has come with pain abdomen and dyspepsia. The dyspepsia is related to food. Is the pain related to food? That would make more sense. Is the pain related to food?
He felt pain after
So
one.
pain
one and a
was
half hours.
precipitated by
Food.
intake of food.
And relief.
Makes sense? And is relieved on?
Vomiting, but not completely.
Partially relieved
Partially
on.
relieved on vomiting.
So stick to those. You can't be repeating again and again. You went to a doctor, then came out of it. You went again to see him in the evening, then went next morning. This is not required. Now, the pain was of no character, you said. You can't have a pain without any character.
So,
It cannot be a character that you like. You shouldn't be looking to put it in either a colicky pain or in a dull aching pain. It's not mandatory. What is the pattern of this pain? How was this pain?
Sir, I asked him about the colicky burning pain. Or
What is the presentation of a colicky pain?
the police will start the attack and I feel like
You can shift. Meanwhile, you can shift to him.
yes, we are sitting. He felt some propelling pain.
What's colicky pain? I'm asking you a question.
So pain comes in attacks, severe attacks, and patient can't lie still. He
See, classically, colicky pain is produced due to obstruction in a tube. And what is the main function of most tubes in our body? To propel. And to propel it, they require which system to be active? Parasympathetic system. Now, if there is an obstruction to the flow of anything in a tube, what becomes hyperactive to overcome that obstruction? Parasympathetic system. So there is extra or excessive parasympathetic activity. Now, most features of colic would be excessive parasympathetic activity. Now, what are these features? Patient would have severe pain, he will be tossing in the bed. Why? Because pressure relieves this pain. Pressure would relieve it. Pressure will relieve the pain. I'm talking about colic pain now. Secondly, he will be tossing because he can control the pain by applying pressure. It may be or it is usually associated with vomitings. What is the cause of vomiting in a colic pain?
central stimulation.
Which stimulation? I told you just now. Parasympathetic stimulation, which leads to vagal activity, which means pyloric spasm. So that will cause vomiting. Then, in addition to that, what you would ask is, sir, abdominal. Now there is excessive parasympathetic activity, which would mean pain would come in spasms, because peristalsis comes in spasm, which is what you were saying. That is spasmodic pain. It is usually the patient, if intensity severe patient is tossing in the bed. 3, it is relieved on application of pressure. What else will relieve this pain? Nidhi? Divya? Antispasmodics or parasympatholytic drugs. This is the excessive activity of the parasympathetic system. So parasympatholytic drugs would relieve it, like atropine, buscopan, Drotin, etc. All these. Thirdly, it will be associated with vomiting due to stimulation of the vagus, which leads to pylorospasm. And this vomiting is without bile, because pylorus is blocked. So don't link it to intestinal obstruction all the time. It's not intestinal colic. Even urinary colic will produce vomiting. You understand? Because that's because of pyloric spasm. Okay? Then comes, it will be associated with what? What will happen to the pulse rate? Bradycardia. Again due to parasympathetic activity. You get tachycardia in sympathetic overactivity or inflammatory pain. So inflammatory pain will have tachycardia. Parasympathetic pain or Colicky pain will have bradycardia. These are the features. Now the pain was, suppose assuming it was precipitated by food, was relieved partly by vomiting. Can you link it somewhere? So the pain was more of a colicky nature than he thought. It fits into the colicky variety. Dull ache would be a different pain, diffuse pain which persists throughout the day, it doesn't come in waves. Now the very fact that food, as soon as you took it, there was activity, then there was vomiting, you can link it. Is that clear? So you can get out of that problem very quickly. Then there is a loss of appetite, which is important. What is significant
Movement
loss?
is also not greenish, it's white to yellow.
Classical gastric contents are coming.
Containing
Yes,
injected
that's a very good point. Now, if you're talking about vomiting, you will talk about the nature of vomiting. Is it projectile or non-projectile? What does projectile vomiting mean?
So it comes out by itself, like
Without
without any
So it is projective, which is again a feature suggestive of pyloric obstruction. But active muscles of the stomach. If the muscles of the stomach are infiltrated, there is no projectile vomiting. So carcinoma of stomach does not normally produce vomitings which are projectile, while idiopathic hypertrophic pyloric stenosis produces projectile vomiting. जो आपको उल्टी आती थी वो दूर तक जाती थी या एक नहीं? So it was a non-projectile vomiting. Non-projectile, which goes in favor of the situation that is the muscles were infiltrated, which goes in favor of a situation that is clear. It's important. Now let's get on with important salient features in the history. Patient has a history of pain abdomen which was increased by intake of food, relieved on vomiting, or the vomiting happened automatically. Vomiting was non-projectile, the contents were just the gastric contents. He never had bile in his vomiting, which basically indicates that there was a pyloric spasm. It's more of a colicky pain that he had. He had loss of appetite.
He just feel hungry but can't eat because
Okay.
of fear of vomiting.
There is anorexia and also loss of weight. How much weight has he
So
lost?
he doesn't know exact figure, he says that his clothes are loosened.
Okay, so the patient cannot quantify the weight loss. In that situation, you mentioned the patient could not quantify the weight loss, but his clothes got loose. If you could quantify, you'll be happy. How much is significant weight loss?
So 10% weight loss means
If it is 15,
so more than say 10%, more than 10.
and if it is in 3 months?
But it's like that.
So, more than 10% weight loss in less than 6 months. So be clear about it. You can't say 10, 6, otherwise I don't care. No. Now coming to the examination. Anything else in the history which you missed out? What are the negative history you would like to say?
So history of bleeding, hematosis or
Nose to hematomesis or melena. What is melena, doctor?
So, melena is a process of
Black tarry stool.
Black tarry stool.
Due to various reasons. But the common ones are upper GI bleed. There can be a melena in a carcinoma of the cecum also. But the cause is different there. What's the difference?
because of slow and protracted bleeding.
Slow protracted bleeding and a gradual passage of the fecal matter. Bacteria act on the blood to convert it into what you need to make it into black. In the upper GI, it's the acids. So the two are different. Now coming to anything else in the history?
Nose to dyspepsia prior to 7 years.
Which dyspepsia is significant in cancer stomach? What is new onset dyspepsia? New onset dyspepsia.
This dyspepsia for the last 3 months.
No, if you don't know, please just say I don't know. It's easier because we're working on it. Now, new onset dyspepsia is a dyspepsia that occurs to an individual for the first time after 40, when he has had no dyspepsia in the past. This needs to be investigated for carcinoma of the stomach. They need upper GI endoscopy. Is that clear? Okay. Now we move on to the examination because we are trying to quickly wrap up the examination. General examination, I told you yesterday what all points to describe.
So the patient has lying comfortable on couch. There is a mild failure, no swelling.
You describe it. What all points you would like to cover in this patient?
His level of his mental state of intelligence, his level of consciousness, his state of hydration, his icterus if any, generalized lymphadenopathy if any, significant
What did I tell you was mandatory?
State of nutrition and
Why did you miss it? He's vomiting. So performance status, nutritional status, hydration status are mandatory. We are not going into it because we already discussed it. And hydration is important because this patient is vomiting. And then you look for nutritional status like we discussed in the morning. Then we look at the we have talked about performance status already. And the mental status for the reasons there can be metastasis to the brain, or patient would be having disorientation due to maybe icterus. And then you get on with examination of the patient specifically. These three have to be covered like we discussed in the previous case. Performance status, nutritional status, hydration status. Any doubts there? Clear? Everybody knows about these three? So in all cases mention this. You're going to lose nothing. Coming to the specific points. If you think the patient, after you examine the patient, going to happen again, look for signs or stigmas of liver disease. Not liver failure. You confuse stigmas of liver disease with liver failure. That's not it. What are the stigmas of liver disease?
icterus,
Start with the sparse hair, icterus, spider nevi, gynecomastia, palmarisma, dupuytren's contracture, clubbing, ascites, caput medusae, testicular atrophy, speed and of course epidermal. Let's get on with the, how many of these stigmas are present? Is the icterus? Where do you look for icterus? Icterus in upper palpebral conjunctiva.
it's clear in the sunlight.
You can see nothing in conjunctiva is transparent. You look at the sclera. You look at the sclera. Okay? Lower palpebral conjunctiva, you look for edema. Is the icterus present?
So with your light you see.
Correct. This light can give you a false. This light is making it look all yellow. And the rest of the general examination is clear. You look for generalized lymphadenopathy and stigmas of the liver disease. Okay. Now we discussed about examination of abdomen yesterday. Can you describe all the points?
should be repeated from lymphadenopathy to level.
Yes.
Then patient should die comfortably.
Okay. Carry on.
On inspection,
Explain to the patient, we discussed in the morning, that we may be examining you, it might hurt you. थोड़ा पेट देखेंगे दर्द होगा तो
पेट
बताइए.
में दिक्कत है ना तो पेट देखेंगे अभी, ठीक है, दर्द तो बता देना बताएंगे.
Okay. This is not scaphoid. Come here. I spent so much time telling you yesterday there is no scaphoid abdomen. Is it scaphoid abdomen by any look? Scaphoid is boat shaped. And didn't I tell you yesterday there is nothing like scaphoid abdomen? Were you there in the class? No, that we had a combined class for that now. Anyway, that's besides the point.
The abdomen is not distended.
Abdomen is not distended.
All quadrants are moving well with respiration.
Okay.
The umbilicus is central in position. The umbilicus is otherwise unremarkable. There are no engorged veins, sinuses, ulcers anywhere. No visible peristalsis, no visible pulsations. Thanks, sir. Thanks.
How do you look for flanks? We'll go there and see.
Yes, sir.
So you'll examine from there, we've covered that part. Flanks look a little full, but you'd like to confirm that because some people have so much of weight that it can look that way. Okay? On inspection, anything else?
And the hernial orifices appear normal.
Okay, good.
No nodules around the umbilicus.
Okay. Can't see renal angles in this position, so don't comment on that. That's what I discussed yesterday. Anything else?
The respiratory movement.
All quadrants are moving well with respiration, equally well with respiration. Okay. How do you examine for that? Come here and show quickly. We have to save time. You get down to the level of the abdomen to look for any visible pulsations, and then you look from the bottom end or the foot end of the patient or the head end, whether all quadrants are moving well with respiration or not. This was discussed yesterday. Then you look for specific organs. How do you examine for liver? Just demonstrate.
भाई साहब आपके ये पैर ऊपर कर लो थोड़ा दुखे तो बोलो आराम से एक ही आराम से लंबी लंबी सांस लो.
What are you looking for?
Looking for the lower boundary of the lungs.
No. First thing I told you yesterday, you look for general points of tenderness by superficial palpation, so that you can avoid that part. Yeah. Okay. The rest was as we discussed yesterday. More or less this is all the same. Clear? You just demonstrate how you look for the liver span, palpation you've done. So can you just show how we really get the same thing can be.
First identify the angle of Louis.
Okay.
This corresponds to the second intercostal space. The second intercostal space you start purposing
In the mid-clavicular line.
in the mid
Okay.
clavicular line.
And how do you go down?
Follow the intercostal space.
That's not what you normally done. You have to go down in the mid-clavicular line. And when you get the dullness, you start following it up in that gaze. This is what was discussed. Can you demonstrate? I have already shown you, that's why I am not repeating it. This has been recorded in this part. The reason why we don't go down here is because you would get a little bit of, sorry, muscle cartilage. That's why you have to go away. But here you would start in the mid-clavicular line. Right? You've seen the liver is enlarged. Why should you know the liver span? You must, sometimes it can happen that the liver is pushed down rather than it is enlarged. To be able to find out the liver span, you must see the upper border also. That is the reason why we do the liver span. This is how you mark the lower and the upper end of the and liver span has to be identified. In all cases, when you talk about liver is enlarged, you can't get away without finding out about the upper border. Is that clear? About shifting the legs, we saw yesterday. Any confusion regarding examination by the doctor? Yeah?
Should I call this will be longitudinal?
Is it longitudinal? Why should you call it? The one that you saw yesterday was transversely stretched. That usually is due to fluid in the fluid. Right? And we talked about the longitudinal. This is pretty normal. And secondly, no scaphoid abdominals. There are hardly any scaphoid abdominals you see unless the patient is totally cachex. Abdomen is not distended usually would suffer. Like he said, it's scaphoid, so it doesn't look like the scaphoid or the bone shape.
How should we differentiate the fullness of the flame in this whole discussion?
Right? It should be relevant, otherwise it is discussed that we are still waiting for shift to work.